Dear participants, the next session is personalized mycology and chronic sinusitis. And I would like to remind you that after this session, there is a lunch break. With the registration, you received 2 codes, which are on the back of your accreditations. And 1 code is for each day for the lunch break. Also, you have a map which shows the direction from this venue to the restaurant, and it's in the city center, around 10 minutes walk from here. Yeah, it's a part of a city called Skadarlia. And thank you. The chairman will continue.
Good afternoon. Welcome to the next session. First of all, I would like to thank Professor Valentina for the invitation to be today, and thank you for coming and attendance for this workshop. I would like to invite first speaker, Timon Aihelas Byzantiadis. He will give talk about diagnostic stewardship in chronic fungal infection, molecular and antigen-based tests. Something I would say new. We used to learn about antimicrobial stewardship, antibiotic. Now we'll see next.
Okay. Thank you very much. Permit me a small introduction. Professor Arsenevich, dear Valentina, and dear friends of the organizing committee, I have to say, I feel very honored and privileged to be again with you here at your scientific works. And I would like to thank you so much for this kind invitation. Very much. So my topic is, thank you, of course. My topic is has to do with diagnostic stewardship in mycosis. And first, I would like to note possibly that there is no actually great difference concerning diagnostic stewardship between chronic or non-chronic infections in fungal in mycosis. Is something to start?
No, not now.
Not now. Okay.
Yes.
Especially because a lot of fungal infections actually in the invasive level or in the not so invasive level, they tend to become more chronic actually, and we have to monitor them in any case. So from a more general perspective, this is a chronic situation anyway, most of them. So according to this, if we try to decrease the unnecessary testing, increase the appropriate testing, improve testing strategies, and reduce diagnostic errors, according to the WHO, this is the meaning of a coordinated guidance and intervention in order to improve appropriate use of microbiologic diagnostics and guide therapeutic decisions. This is the most crucial, to guide the therapeutic decision. All these are to be done in order to guide these decisions. So, of course, because there are some concerns concerning the diagnostic stewardship, and especially for fungal infections from the part of the invasive fungal diseases, we all know that antifungals are over or misprescribed in up to 50% of the cases. And of course, this is a great concern because it guides easily to antifungal resistance. Another part, which comes from the superficial fungal infections and mostly the dermatophytosis, there the reality is that they affect approximately 1/4 or more than one quarter of the global population. So the numbers are vast. Although this is the reality, there is a widespread practice up to more than 80% that the treatment is totally empirical, with no confirmatory test at all. And this is again, of course, a great concern towards the creation of antifungal resistance. Also from the part mostly of the lab, this concerns mostly the lab, the mycology lab, there are some challenges. Molds are not so frequent. They are, mostly in the invasive stage. They are less than 10%, but they are so fatal. The mortality is more than 30%. And so it's an issue. We can miss this diagnosis, and not only miss the diagnosis, but we must be prompt. We must have a fast diagnosis. Also, the diagnostics test, we all know these are of low sensitivity. And on the other hand, the infections many times are not specific. They don't have specific signs or symptoms. Although the treatment continues despite the negative results we provide as labs, and although there is an increased negative predictive value of the tests. Also, the testing performance varies between the populations, and they are ordered in their own populations sometimes. So this leads to excessive treatment or unnecessary testing. The availability of tests is not equivalent in all institutions and in all populations. And although there should be, they are not available even centrally. So this is a problem. It's a real problem, mostly also in our broad region of Balkanic Peninsula. The accuracy of biomarkers is influenced by antifungals. This is a well-known situation, again, either for prophylaxis or for treatment. There is a constant counteract between the clinical department and the mycology lab. And if we come from the part of the physician now, there the clinical colleague has to answer actually three crucial questions. Is there an infection? Is the first question he has to answer. What is the possible fungal pathogen of this question? And what will cure this? So he is very much based in our results. And between the sampling, the fungal identification, and the sensitivity testing that is so crucial for antimicrobial stewardship, he is obliged many times to use to make empirical use of broad spectrum antifungals that helps again the growth of antifungal resistance. So in order to help him, to help the clinical colleagues, we come as labs by the use of rapid diagnostic, mostly molecular, but also antigen-based techniques to reduce the time he needs in order to decide an evidence-based treatment and, above all, prompt and effective. But again, there are more challenges for the lab if we want to be based mostly on the lab as we are laboratorians. First, there is an overabundance of technical capability, data, and information, so vast numbers that it's so difficult to absorb them and understand them many times. There is also a pressure for high cost control, many times influenced also by commercial reasons. We all know this, and especially in the age of molecular technology. And much more, this pressure is not always completely relevant, I mean clinically. Also, there is an overdiagnosis or an underdiagnosis that could guide to incorrect treatment. Let's think, all of us, about what we feel if we want to evaluate or not evaluate a fungal colony that is growing on our plates. Are we going to report it to the clinical department or not? So are we going to do possibly overdiagnosis or underdiagnosis? It depends on us and how we evaluate this, let's say, formation of a fungal colony. In order to be more safe, more practical, and more useful as labs, we have to follow these specific guidelines that are available now, specific recommendations. Also, we should be based in our experience and knowledge, our own experience and knowledge, and don't be afraid to take initiatives. But there is always a great difference between what we want to do as labs, what we can do, and what we should do. So in order to be more effective, it's a good idea to follow at least the guidelines and the recommendations. So continues this counteract between the lab and the clinical discussion continues by the receiving of the specimens, the biological specimens, also by reporting towards them, I mean the clinical teams, our results. Also, as labs, we produce and send results to, let's say, surveillance team of the hospital or the center we work. them by their term, they are going to provide specific data and guide the treatment now, guiding the clinical team, but also by analyzing the data we provide to them, they should provide also specific data to the national, let's say, antimicrobial resistance surveillance system. If all this happens, then the system works perfectly. And at the end, we have to realize that the diagnostic stewardship, also in mycology, is just a part of the total antimicrobial stewardship. And all of us, clinicians or laboratorians, we try by the appliance of all this to have a better use of antifungals in order to have reduced resistance. This is the ultimate goal, and prevention of complications. So, concerning the laboratory approach, there are some improvements we can do either at the pre-analytical, the analytical, or the meta-analytical phase of our effort of diagnosis. In simple words, the ordering stage, the performing stage, and the reporting stage. And although there are so many things we can do at the first and the third level, there are so many things still we can do at the performing level. So the second one, in order to reduce the time, be more effective, etc. And so the lab, by all this, will help the clinical department with the right test for the right patient and the right time in order to be accurate and clinically relevant and influence positively the evidence-based treatment. In this subject, there are some more technical, let's say, issues we have to face as laboratories. The sensitivity, the specificity values, the predictive values, so much important for mycology. Actually, the testing volumes, we should do our tests in very few quantities of biological samples. This is a target. The diagnostic yield, the laboratory feasibility, what we can do and what we should do. And of course, very crucial, the cost. We should be cost effective and have a clinical impact. This is crucial. What we do must have a clinical impact. In our days, there are so many tests around us, according to the British Society also for Medical Mycology, and these are antigen-based tests, molecular tests, more conventional tests, etc. So many. And independently of what system we target, the blood, tissues, fluid, respiratory, neural system, whatever, so we have to make a choose, or better, we have to make a combination. But we should never forget that, and we should never neglect this humble, so cheap microscopy, classical microscopy, that it's a so powerful tool, could offer us immediate diagnosis. Although it has low sensitivity, it is dependent absolutely on the microscopist's experience. And here come the crucial issues of education. How well educated we have our, let's say, lab personnel, specialist personnel, etc. Because we realize more and more that, at least, I don't want to offend anybody, of course, but younger colleagues that are superb, for example, in molecular techniques or whatever, many times they cannot identify not even a single fungal colony in their microscopy. And many times they avoid to do it. It's a common habitude in our days. Also, we should never forget the culture. That culture is essential, especially for identification, susceptibility, and typing in our days. Although, again, it has low sensitivity and often it has a slow growth. Okay, but again, we should not neglect these two crucial exams. So, coming to the non-cultural techniques, again, even in our days, these are less known to the clinicians, the availability to offer non-cultural techniques. And many times they are asked with no program, or no schedule, or no target why they ask this or the other clinical antigen or non-cultural technique. So they are more rapid, of course, and so they can help us to the faster selection of treatments. They are, of course, of higher cost, but in long term, probably not, because the more you do, the less expensive they become at the end. They have high analytical sensitivity, or I should say moderate analytical sensitivity and specificity, but they have, and this is crucial in mycology, very high, many of them, negative predictive value. And this is very useful in the mycological diagnosis. They have lower clinical specificity. For example, think about the decision of a real infection or a colonization. So this decreases the specificity when we have to decide, and many times we cannot decide if we have before our eyes an infection, a real infection or a colonization. So this comes due to the lower specificity. They are useful for avoiding the spread of pathogen due to their the ability of faster detection. A few of them, mostly NGS and whole genome sequencing approaches, they provide vast quantity of information, many times unknown. Many times we don't know what to do with the information they provide. And they could help us with more rare diagnosis because they have the ability to find pathogens that possibly cannot be diagnosed by conventional methods. Also, many times they detect the pathogen, but unfortunately, they cannot prove the disease. And this happens mostly with molecular techniques and mostly with the multiplex approaches that have lower specificity due to the multiplex identity of them. Also, the positive predictive value depends on the possibility of the existence of the specific pathogen we search. Because if the disease is not there, about which positive predictive value to speak. And also there is a need for expertise, although we say that, yes, okay, this can be done possibly more automated and in a more, let's say, everyday level. They still have a great need for expertise in analysis and interpretation, especially due to this much greater number of information. And it's very well accepted that the use of these new rapid techniques, under quotations, rapid techniques, because many times they are not so rapid, although we call them rapid, they will not improve the antimicrobial treatment and the outcome if we don't have an active antimicrobial stewardship. And the great help that the lab can offer to this antimicrobial stewardship effort is the therapeutic drug monitoring of antifungal drugs. So much discussions about it. I support it very much as a personal opinion and could be done also either by bioassays there or by more analytical chromatographic assays there, like an HPLC system. And again, if we come back to our previous slides, here is let's say, the ordering phase, here is the performing phase, and here is the reporting phase, and here is a great part of the work we can do. So, whereas by the conventional methods, possibly we could need something like 7, 8, 10 days to come to a conclusion, by applying the more modern technology, more molecular workflow, this time can be decreased to up to 1 or 2 days or even a few hours. This is, although is an old slide, this is a good depiction. There is the conventional approach, there is the more molecular, let's say, approach. In the cases of candidemia, how much time, how many days or hours we need in order to start the antifungal treatment in candidemia, which is so crucial after the collection of the blood. So by the conventional methodology, we could need something like up to 10 days with a median, let's say, 4 to 5 days, but with the molecular techniques and especially with multi-DOF, especially the direct multi-DOF, I will explain a little bit later, the PNA fish, and mostly the T2 candida, could decrease this in just a few hours. Of course, most of the times we should need something like 3 days. And also we should never forget that the time we need for conventional, but even also for not so conventional approaching, depends also on the pathogen itself. So for example, for Candida tropicalis, we should need something like 20 hours to have a positive culture, whereas for Candida glabrata, we could need something as more than 70 or even 80 hours. So the time we need at the end is greatly depending on the pathogen itself. And of course, when we speak about antigen-based techniques, these are mostly based on components of the cell wall of the fungal cell. Here, mostly the glucans and the mannan proteins. And the best test among them is the test that considers the detection of the capsular mannan of the Cryptococcus. Could be done also by agglutination test that is much better if you want to also to have titers, and also by lateral flow assays, mostly for screening testing, the latter, and they can be done also in CSF or serum. They are superb tests concerning their sensitivity and their rapidness of testing. And also here, please follow the colors here, galactomannan, the green, let's say blue, the mannan and the mannan, and white, the glucan test. Here, you have several tests, mostly for Aspergillus, Candida, or even fungal testing. Okay, concerning galactomannan, they can be used in serum, BAL, CSF, and other fluids. Concerning the mannan and the mannan, and please use them in combination or try to persuade the clinicians to ask them in combination. They never do. They mostly ask separately for mannan or separately for anti-mannan. The conclusion is much more safe when we combine these two tests in candidemia or in candida invasive diseases. This can be done in serum. The beta glucan can be done in serum. Recently, there are big discussions about the ability to use it also in CSF. And also we have this let's say, extracellular glycoprotein that is produced during hyphal growth in serum, BAL, and urine. So we have here also the lateral flow assays and lateral flow devices that can count also the same substances. They are more for screening tests. They again have a high negative predictive value, good sensitivity and specificity levels. They are much better. It's much better if they are combined to PCR. If we go to a little bit more chronic situations, here we have the specific IgG antibodies against Aspergillus. They are very useful tools, especially for chronic inflammation and disease, and also for the monitoring of the disease or the response to the treatment. And if we go to allergic aspergillosis, here a useful tool is the IgE antibody. But again, in this situation, the IgG antibodies against Aspergillus are many times quite useful. If we want to conclude in this slide, we should remember that all these tests that are very useful, they have a moderate sensitivity and specificity. They have, let's say, good predictive values. All of them have very good or excellent negative predictive value. And this, as I already said, is crucial in medical mycology lab. They are much better when they are combined, not only a test, but possibly 1, 2, or 3 tests combined to conventional also approach, not only trying to diagnose by antigen-based tests. This is not a good idea, actually. They are much better when they are repeated, so you should need more measurements than 1, or even 1 per week, possibly 2 per week, for example, for galactomannan, and they are very much influenced by treatment. even the molecular tests. Also, the very precious conclusion after by the use of all these tests is that we have to keep them for the high-risk patients. Otherwise, they are useless and they are not at all cost-effective. So please keep them, for example, keep galactomannan for the high-risk patients. Don't do galactomannan to everybody. It's completely useless. And here is a nice depiction of the lateral flow assays or devices. We all know them also from other pathogens or for more everyday, let's say, testing, the pregnancy testing. It's actually a lateral flow assay. So as apparatus, they are very common images to us. And here is a summary of the most known, well-known commercial actually lateral flow assays or devices that can be used as point-of-care tests, or either for Cryptococcus or for Aspergillus or for endemic infections. And they have a CE mark, and they can be used, many of them, freely in the European continent. Also, a few of them have FDA approval and then can be used equally in the United States. And if we discuss a little bit about the molecular testing, it's good on time? Okay, almost, yes. If we want to discuss a little bit for the molecular testing, here we have two main approaches. Or we have one unique target, the more classical, let's say, PCRs, even in-house PCRs. Please trust your in-house PCRs if you can trust them and you are very used in a good application of them. So we have PCRs in-house or commercial for Aspergillus, Candida, Cryptococcus, Pneumocystis, and more recently even for Mucorales, the more crucial, let's say, pathogens, at least at the invasive level. But also we have these syndromic panels that are multiplex panels. And among several pathogens, we have also the fungal pathogens. We have in their panel also viral pathogen, bacterial pathogens, etc. Due to this reason, they are less specific. And sometimes they could provide false positive results. So many times we have to approve this result or to confirm this result by applying, let's say, then a unique target PCR. Okay. Most of them, they are targeting the ribosomal DNA of the fungal cell and mostly the ITS regions, although we have also other approaches. And here we have also other, let's say, more alternative molecular approaches as the in situ hybridization, the magnetic resonance T2, mostly for Candida in our cases, very expensive though as approach, and very closed system. Also the multi-DOF MS, a revolutionary methodology in the identification of pathogens, and especially at the direct approach from positive blood cultures without the need of reculturing on the plate. This helps us very greatly in the reducing of time, and also the sequencing, the classical sequencing, Sanger sequencing, that is still very, very useful in the identification, the phylogeny, or even the diagnosis, and the NGS and whole genome sequencing approaches that are very, very useful in our days for epidemiology, clonal outbreaks, infection control, antifungal stewardship, crucial for this one. And if they are combined to metagenomics, they could be also useful to the diagnostic approach. And here, permit me, this is the NGS system and the whole genome sequencing apparatus of our lab in Thessaloniki. We are very proud for them, so I permit me to show them to you. So here actually is a summary of all this concerning the molecular techniques. You can see here how much less time we need after applying this. For example, the film array is something like 1 hour after the positiveness of the specimen, or just a few hours, 4 or 5 hours after the blood collection for T2 Candida, and direct multi-DOF, I mean, without the need of reculturing on the plate, directed from the positive bottle of blood culture, something like half an hour. PNA fees similar, almost similar. Whereas for the conventional approach, we could need something like more than 1 or 2 days after the positiveness of the culture. And by ending, what is actually the basic element of success after applying all this diagnostic stewardship, either in general microbiology or more specifically in mycology, which is our involvement? The basic element of success is the frequent and good communication between lab and clinical department. Whatever we knew previously, we must forget it as approaching, because here the communication is obligatory, is necessary if we want to impose antimicrobial stewardship programs. There should be this counteract between the lab and the clinical department in order to have this stewardship. Otherwise, we don't have stewardship. We have something else. So for this, crucial is the free exchange of information without obstacles and hesitations in order to facilitate the decisions. And the main operating criteria, I think, to my point of view for approaching, is that we should have clinically relevant results. So the methodology and the finding we are going to try, apply, etc., should be clinically relevant. So we don't do whatever we want. Okay, everything we do should be clinically relevant for the benefit of the patient. And by this, I would like to thank you once more by this spring photo from our region in northern Greece. Okay, thank you very much.
Thank you for a really nice overview, and we probably open a lot of questions regarding these topics. I like your conclusion that really is essential collaboration between clinician and the laboratory, and we can discuss later. I think at the end we will have questions for all the speakers. Thank you once more. We will continue with the next speaker. I will invite Professor Miha Maras. He will give talk One Health approach and non-dermatophyte modes. One also very interesting topics. A lot of the last few years we talk about One Health approach in different fields of microbiology, and that's something for me and probably for many of us new also approach in fungal infection in general.
Thank you for the introduction. I would like to thank Professor Valentina Arsenievich for this kind of invitation and for the opportunity to meet old and good friends again. The topic is quite challenging. To talk about One Health approach in fungal sinusitis, it's not an easy one. I try to do my best, and you will appreciate if I succeeded or not. It's not working. Oh, okay. Just a few words about One Health approach. According to WHO, One Health is an integrated, unifying approach that aims to sustainable balance and optimize the health of peoples, animals, and ecosystem. So this approach addresses the interrelations between animal health, human health, and the health of ecosystem and the entire environment. Probably the fungal infections are one of the best examples of One Health approach, at least for fungal infection produced by filamentous fungi that are existing everywhere into the environment. They are in the soil, mainly in the soil, and after that they contaminate all other environments, water, air, food, feed, everything. So humans and animals are facing with enormous invisible particles, fungal spores, in fact, And this enormous amount of fungal spores jeopardize our health in particular conditions. And of course, being into the environment and being exposed to various environmental conditions, like, for example, use of pesticide in agriculture, climate changes, etc., this fungi react, adapt, and modify their behavior, both in relation with humans, animals, and environment. Concerning the interest, it's working. Here we have a graph with a number of papers concerning the One Health, and here another one concerning the One Health plus fungi. And we can observe that after 2010, the number of papers slightly increased based on the interest that the academic community has on this topic. Okay, let's move to the multifaceted aspect of fungal sinusitis. Human part, the first one. Just a short clarifying of the terms. We call it sinusitis or rhinosinusitis. I prefer rhinosinusitis. Why? Because the inflammation of the nasal cavity is usually associated with inflammation of the sinus lining. And sinusitis is associated with inflammation of the nose mucosa. In terms of classification, depending on the criteria, we have many classifications. Acute, subacute, and chronic rhinosinusitis, according to the duration, viral, bacterial, fungal rhinosinusitis, allergic rhinosinusitis, and according to American Academy of Otolaryngology, the classification by duration is this one. Any evolution more than 12 weeks indicating chronic rhinosinusitis. If you consider more criteria, for example, invasiveness, duration of the disease, presence of eosinophils, immune status of the patient, and other criteria, you can obtain a more or less complex classification. The best one is that one, starting with the detection of the fungus into the tissue or on the tissue. So we are discussing about fungal rhinosinusitis. This disease can be invasive, that means fungus within mucosa and other tissues. Non-invasive, fungus remain on the top of the mucosa, the superficial part. The invasive one can have different evolution: acute invasive, granulomatous invasive, and chronic invasive. Non-invasive form can be non-eosinophilic or eosinophilic. Between acute invasive fungal rhinosinusitis and chronic one, there are different clinical aspects, mostly depending on the immune status of the patient. So the more immunocompromised the patient, the more invasive the disease. And the worst one is acute fulminant fungal rhinosinusitis. Immunocompetent patients develop granulomatous pathology, the inflammation is quite localized. And between acute and chronic granulomatous disease, there are some intermediate forms in diabetic patients. The first type of fungal rhinosinusitis, the acute fulminant one, is produced mainly by Aspergillus and Mucorales. It has a short course, less than 4 weeks, sometimes less than 2 or 3 days after diagnosis. Is mainly characterized by vascular invasion with subsequent thrombosis of different types of vessels and the appearance of black scars, what we see on the patient. In fact, a dry necrosis produced by the vessel thrombosis. The prognosis is poor, the lethality is high due to the spreading of the fungi to other areas, eye, brain, etc. The fungi are growing very fast into the patient body, like they are growing into the petri dish in the lab. Of course, this disease is found in immunocompromised individuals. Diabetes mellitus ketoacidosis, corticotherapy, COVID-19 immune dysregulation, deferoxamine treatment, and other conditions. Of course, neutrophils are very important in host defense against this invasion with Mucorales, especially, and Aspergillus also. And levels below 500 cells per ml being very, very problematic for the patient. Just few examples of acute fulminant invasive fungal rhinosinusitis. Here, massive involvement of the left maxillary ethmoidal and frontal sinuses. Here, rhinosinusitis, black eschar in a diabetic patient, and here severe complication, thrombosis of the right cavernous portion of the internal carotid artery. So it's a very serious clinical condition with high lethality. Next disease, granulomatous invasive fungal rhinosinusitis. It's quite rare, uncommon, and is encountered in immunocompetent patients. That's why we have a quite localized lesion of the disease, granulomatous. It's a chronic condition, so the evolution is more than 12 weeks. It's more common in tropical regions, and the most important causative agent is Aspergillus flavus. The predominant clinical feature includes proptosis with enlarged muscle in the cheek, nose, paranasal sinuses, and orbit. CT findings are not different to that of chronic invasive fungal rhinosinusitis. So they are, in terms of imagistic, the same aspect. Histology brings some information. Fungal tissue invasion and granulomatous reaction are considered important for diagnosis. And you can see in the biopsy, fibrosis, giant cells, sometimes including degenerated hyphae, and narrow septate hyphae, branched at 47 angle that are highly suggestive for Aspergillus. Not only for Aspergillus, but in this clinical condition, we should keep in mind Aspergillus or flavus. Chronic invasive fungal sinusitis is produced mainly by Aspergillus fumigatus. It's a slowly, being chronic, it's slowly destructive disease, more than 12 weeks, sometimes many years. Patients are usually immunocompetent or having mild abnormalities of the immune system, like diabetic patients or patients treated long period of time with low corticosteroid doses, or patients suffering with ADS. The clinical picture is indifferentiable from granulomatous invasive fungal rhinosinusitis, but the ethmoidal and sphenoidal sinuses are more involved. Histological findings indicate the invasion of fungi into the sinus mucosa with a dense accumulation of fungal hyphae and occasionally vascular invasion and chronic inflammatory reaction. If you are discussing about Aspergillus fumigatus, probably the concentration of IgG, specific IgG, is high. Allergic fungal rhinosinusitis, we are facing with disease that is not really an infection, it's an allergic phenomenon. It's non-invasive, it's chronic, still often misdiagnosed in the lab because sometimes physicians do not perform different lab investigations to clarify the etiology and all other aspects. It is characterized by the presence of eosinophilic mucin, or allergic mucin, containing fungal hyphae within the sinuses and humoral response to type 1 IgE-mediated hypersensitivity to fungi. Which fungi are involved? Aspergillus, many species, but also dematerial fungi with high content in melanin, like Alternaria that are existing also in temperate climate, so in Europe, Biporellis and Curvularia and Exerochilum that are encountered in tropical area. The pathophysiology of this disease is very similar to allergic bronchopulmonary aspergillosis, so we'll have elevated levels of specific IgE against Aspergillus fumigatus in case of Aspergillus fumigatus involvement. And if you take a sample from this allergic mucin, you will see eosinophil predominant inflammation, Charcot-Leyden crystals due to eosinophilic degranulation, and hyphae. The diagnostic criteria, there are different opinions into the literature, but all of them take into account this major criteria, referring the status of the patient, the presence of nasal polyposis, characteristic of CT findings, obligatory presence of allergic mucin or eosinophilic inflammation, and positive fungal cultures and positive fungal smear. Few clinical aspects: thick, adherent mucose allergic mucin into the sinuses, into the nasal cavity. And if you obtain a smear from that allergic mucin, you will see eosinophilic clusters and Charcot-Leyden crystals, where the black arrows are. And on the right, a lot of fungal hyphae that are stained in black with the gomboremethenamine silver stain. Fungus ball, also called mycetoma, it's a dense accumulation of extramucosal fungal hyphae, usually within one sinus, especially the maxillary sinus. Most cases are related with stomatologic procedures, for example, dental implants or root canal treatments. So most cases are odontogenic and or iatrogenic. And it was observed a particular relation between the use of zinc in different products, like dental sealers, and overextended of these dental materials containing zinc into the maxillary sinus. So the zinc is metal that, like iron, increase the growth velocity of the fungi. So they are like iron, they are like zinc, and also other metals. And these metals are stimulating the growth of the fungi, in particular Aspergillus nigricans. Diagnostic criteria: radiological evidence of sinus opacification with or without radiographic heterogeneity, and signs of dental procedures, of course. Mucopurulent, cheesy, or clay-like material within the sinus, and a dense conglomerate of hyphae separate from sinus mucosa. That's why we call that the fungus bone. And here we have a section through this mesotome. Of course, thickening of or sclerosis of the sinuses wall is possible due to the pressure exerted by the fungus bone. And less dangerous, let's say. In fact, it's not a disease. It's the localized fungal colonization or saprophytic saprobic infection. It's not so correct, this name. It refers to the visible fungal colonization of the mucous crust seen within the nose or paranasal sinuses. In fact, we are discussing about the presence of a biofilm formed by fungi on different non-viable structures in the nose or paranasal sinuses. And this aspect are seen during the rhinoscopy. Patients are usually asymptomatic and may present with a false smearing odor. The mechanism that is proposed for this condition is a dysfunction of mucociliary apparatus after previous surgical ENT procedures. And let's move to the animal. Dogs and cats, our pets, are also suffering of rhinosinusitis, in particular fungal rhinosinusitis. And what is important from one health point of view is the fact that dogs are sensitive sentinels for environmental fungal load. So if they are exposed to an increased number of fungal spores in a particular area, or the fungi in that area are, for example, azole resistant, the cases in animals appear before the cases in humans. The dolichocephalic breeds are exposed with long nose, more air, more space in the nasal cavity. They are suffering of chronic fungal infections, typically produced by Aspergillus fumigatus, that invades the dog nasal cavity and frontal sinuses. Symptoms are not characteristic, including sneezing, nasal pain, rhinorrhea, appetite reduction, swelling of nasal region, and chronic nasal discharge. And in some cases, the pigmentation of the affected tissue and ulceration of the nostril are characteristic. The diagnostic is mainly based on rhinoscopy, and you can easily see the cover of mucosa with whitish patches. In fact, that are Aspergillus fumigatus biofilms with no sporulation. Of course, we can perform also CT scans to evaluate the severity of bone destruction. It's a very characteristic moldy appearance of the nasal mucosa. In cats, the same, but the disease is less frequent than in dogs. In cats, brachycephalic breeds are more predisposed. We have two forms, rhinosinusoid and sino-orbital forms. We can observe during the CT scan that some granuloma are formed, and this granuloma induce specific symptoms according to the affected areas. In cats, immunocompromised individuals are more susceptible, and we have, like in humans, infection with retroviruses, like feline and leukemia virus and feline immunodeficiency virus. Concerning rhinosinusial aspergillosis in pets, we have chronic, mainly chronic forms, non-invasive or invasive. Fungal sinusitis is not traditionally contagious, but shared exposure to environmental reservoirs creates zoonotic risk clusters, and the cross-specific surveillance is important from one health point of view in order to monitor the fungal isolates from companion animals and identify the appearance of resistant traits, for example, azole-resistant Aspergillus fumigatus. And the last side, environmental health. Fungi are everywhere, especially the spores of filamentous fungi. They are opportunistic, so only in particular conditions they can produce disease. The main role of this fungi is to decompose the decay matter, organic decay matter into the soil. So they produce spores. These spores are so tiny and can be airborne and can contaminate air surfaces, both in indoor and outdoor spaces. There are a lot of environmental drivers that can impact the fungal reservoirs and spore loads into the atmosphere. And we are discussing here about the natural environment, built environment, about climate changes, about interactions with other living organisms on Earth. Few words about fungal reservoirs and spore load that are influenced by indoor factors. There are a lot of factors encountered into the limited spaces, indoor spaces, that can conditionate the multiplication of fungi and release of the spores. The use of damp building materials like those cellulose-based, poor ventilation and high humidity, contaminated air conditioning units, presence of pets that bring fungal spores from outside, and overwatered flower pots that are incubators, real incubators for the fungi, and they release a lot of spore inside. All these conditions increase the exposure to fungi, potentially resulting in sick building syndrome, that it's association of symptoms, not real an infection. It's related with extrolytes, with mycotoxins and volatile organic compounds produced by fungi. But also allergic diseases and infectious diseases are possible after exposure to this increased number of spores. Outdoor factors that are influencing the fungal reservoirs and spore loads are related with the excavation works, the fungi being into the soil, into the compost. When we excavate an area, we aerosolize all of these spores. Intense urbanization and built environment, and here we should discuss about the urban heat island effect. There is a trap heat into the cities that promote the survival of thermophilic fungal pathogen even into the cold season. Associated pollution, we know that PM 2.5 can act as a carrier for fungal spores and depositing them into the lower airways. Gardening and farming activities are also related with spore load exposure. And like in the previous slides, all these conditions can increase the risk for allergic and infectious disease. The climate change is also a risk multiplier. Why? Because climate change may expand the areas where disease-causing fungi can live in terms of ecological preference for an appropriate temperature range. The rising of global temperature favor thermotolerant species, for example, Mucorales, but also Canda auris. It's a hypothesis that the climate change adapt the Canda auris to humans. And last but not least, the climate change increased the number of diseasing plants and the need of antifungal pesticide used in agriculture to counteract this phenomenon is related with resistance to therapeutical antifungals. 1/3 of total pesticide used in agriculture are azoles, fungicidic pesticide that are spreading into the crop field. And just an example, during 2010 and 2021, approximately 120,000 tons of azoles were used in agriculture only in EU, with an average of 10,000 tons per year, that meaning 10 milligrams of azole per square meter. That is quite a huge amount that pose in very important pressure, selective pressure on the fungi, especially Aspergillus fumigatus. As you can see, all these fungicides, propiconazole, bromoconazole, tebuconazole, etc., have the same mechanism of action like therapeutical azoles like itraconazole, Vorico, Posa, etc. Namely, the inhibition of lanosterol 14 alpha demethylase or enzyme CYP51A. And the administration of this pesticide poses an enormous selective pressure to the environmental isolates and fumigators. And as you know from the literature, a lot of point mutations in gene CYP51A, especially in tandem repeating regions of the promoter of the genes, are related with resistance either to all azoles or to resistance to particular agents like voriconazole or isaconazole, or reduced sensitivity to Posa or itaconazole. The infection with azole-resistant Aspergillus fumigatus is an important cause of mortality, especially in severe flu patients, oncohematological patients, and COVID-19 patients. An actual picture of the regions that are affected of this TR mutation in Aspergillus fumigatus, and you can observe spreading all over the world. And if we are discussing about the frequency of this resistance isolates, it varies between 0.3 in Canada and 47.1 in Colombia, with an average of 6 up to 20% in Europe in environmental isolates. And the last part, few words about the fungi, the main actors of all these clinical conditions. Mucorales are the most dangerous pathogens, they being involved in acute invasive rhinosinusitis, not only, but we are discussing about this now. Among mucorales, Rhizopus, mucor, Listeria are the most aggressive threats. The most important aspect in mucorales infection is the ability to penetrate vessel walls, causing thrombosis and infection. The spore release after the sporosis disruption have an enormous capacity of aero contamination. Each small black dot existing on this petri plate contains between 70 and 2,000 small spores. Each black dot. Imagine the possibility of contamination. Mucorales are performant iron acquisition organisms. They produce very performant siderophores, able to attract iron from the tissue and also from the complex iron deferoxamine, iron deferoxamine. As risk factors for infection with mucorales, malignant hemopathies, neutropenia, COVID-19 immune dysregulation, corticotherapy, and also ketoacidosis diabetes. Aspergillus species and Aspergillus fumigatus as a main actor. They are ubiquitous in soil, especially in compost heaps, where they are decomposed, decaying organic matter. Aspergillus fumigatus has a ability to grow between 12 and 50 degrees, and their conidia can survive up to 70 degrees, a condition normally encountered into the compost. What makes Aspergillus fumigatus such a successful pathogen? Conidia have anti-complementary activity, thus reducing the phagocytosis, so it is protected after engulfing by phagocytes. The conidia are covered with a particular protein called hydrophobin that maintain the surface dry, and this is associated with the long persistence of Aspergillus fumigatus spores into the air. They contain melanin that protects conidia from UV radiation and also has antiphagocytic activity and inhibits cellular killing. Is able to produce numerous secondary metabolites, extrolytes, some of them inhibiting the mucociliary clearance apparatus, some of them, like gliotoxin, exhibiting various immunosuppressive activities. Galactosaminogalactan, or shortly galactomannan, that is secreted during hyphal growth, can induce neutrophil apoptosis and is related with the production of anti-inflammatory cytokines. And there are many other virulence factors making Aspergillus fumigatus a successful pathogen. And last slide, the demetriaceous or pigmented fungi. They are involved in allergic phenomena and allergic fungal rhinosinusitis. There are few species involved: Bipolaris corvularia xerophyllum, with they are endemic in tropical regions, but also Alternaria, Aspergillus that are existing in our region. They contain higher amount of melanin. This is normal color, brown, due to higher concentration of melanin. Melanin that offer protection against the host immune-derived reactive oxygen species. And this demetriaceous fungi, through their spores, are able to elicit a strong Th2 mediated responsive with the recruiting of eosinophil. That's why we have allergic mucin into the patients. There are also rare and underdiagnosed fungi that can be identified now with different molecular methods. And we are discussing about Fusarium, that is intrinsic resistant to many antifungals. Lomentospora prolificans, the former Pseudosporium prolificans, a multi-drug resistant fungus, and Schizophyllum commune, it's a basidiomycete fungus that can grow inside the nose and sinuses like a mushroom. Just a few words about my presentation. Rhinosinusitis is a common condition in general population. In the US, there is estimated 8% of total population, all etiology rhinosinusitis. Of course, among this 8%, probably 0.5 up to 2 are chronic rhinosinusitis, and a small number are fungal rhinosinusitis. We have a broad spectrum of clinical entities belonging to fungal rhinosinusitis from acute to chronic. The fungal etiology comprises opportunistic saprobic species existing in the soil. We need specific diagnostic approach and personalized management. Culture is not enough. Biopsy is not enough. CT scan, MRI is not enough. We should put all together in order to proper manage the patient. The environment has an important role. It is the main source of fungi. And of course, the patient immune status is essential for the progress of the disease and for the success of the treatment. Thank you for your attention.
Thank you, Professor Mihai, for excellent presentation. Now, some of you probably will open more questions. We really introduced different topics and some challenges for mycology diagnostic, and especially for young people to see how is challenging working the mycology compared with the other branch of microbiology. Thank you once more. We will continue with the next speaker. Is Sandra Pekic-Đurđević. Sandra will give talk about complication of chronic fungal sinusitis, systemic review, and cases from Serbia.
Thank you for this kind introduction. Welcome all. I want to thank Professor Arseniy Arsenievich for the kind invitation to participate in this postgraduate meeting. It's a great privilege to be here among the friends and young doctors. I will talk about the chronic fungal rhinosinusitis, about our two cases, which we solved together with Professor Valentina 15 to 17 years ago, where our collaboration started, and it was very successful, I think. As we already heard from Professor Maras, this is a spectrum of the disease of paranasal sinuses, which can affect people who are immunocompromised or immunocompetent. We heard already about the classification of the disease according to the duration, to acute or chronic. We heard about the duration for diagnostic criteria for acute or for chronic disease, and according to the degree of tissue invasion, it can be non-invasive or invasive. And I will talk a little bit more about allergic fungal sinusitis and about chronic invasive, because this was the case in our two patients. Also, Professor Maras told us about the immunocompetence of the patients and their tendency to have some different form of fungal rhinosinusitis. Atopic host, they have allergic fungal sinusitis, which is the most common form of the disease, underdiagnosed, as we heard already, but very important because it can be with very few symptoms, with long duration of the symptoms, but it can complicate it, as it was in our patient's case. And immunosuppressed patients with this acute form of the disease, and other forms in immunocompetent hosts also. The prevalence is increasing in last decades, and there are several reasons, as we already heard, increased awareness, which is very good, antibiotic overuse, which is not good, and immunodeficiency states of the patient, which is increased prevalence also, because the malignancy are much higher in incidence now, acute leukemia and lymphoma patients. Also, a lot of patients are treated with chemotherapy, they develop neutropenia, a lot of patients from different parts of medicine that are treated with high doses of glucocorticoids for a very long period of time, and they become our patients with iatrogenic Cushing's syndrome. Also, there are patients with transplanted organs, solid or hematopoietic stem cells, immunosuppressive therapy. We have also a lot of diabetic patients in our practice, and rare disease Cushing's syndrome as endogenous disease. I didn't tell you I'm a clinician, I'm an endocrinologist working in University Clinical Center in Belgrade. And this is the reason why endocrinology is the part of my presentation. The most encountered fungal species, we also heard from experts about them. I will talk about the complications of fungal rhinosinusitis in patients with chronic disease, because some of them may cause bone erosion and propagate to anatomical structures near to sinuses. Especially the focus will be on sphenoid sinus, because this is the structure less aerated compared with other sinuses, and it is very close to brain, to sella turcica, to pituitary gland, and to other parts of our brain. Every sinusitis can cause bony changes because of long duration and can propagate to cavernous sinus, which is on the left and the right side of the pituitary gland. This is pituitary gland with the sella turcica, and we have on the right and on the left side the structure which is called cavernous sinus. It contains internal carotid artery and three very important cranial nerves, third, fourth, and sixth cranial nerves. And above the pituitary gland is the optic chiasm. So when the patient has some problems here spreading from the sphenoid sinus, they can develop the changes in their vision.